Hello and welcome to Sunset Television. I am Vishal Dahiya and you're watching our special show India Fights Back, where we talk about India's battle against COVID-19 pandemic. And as all of us are aware, in this particular battle, one very important aspect is the vaccination drive, which began on 16th of January. We have achieved quite a number of milestones so far, and in the second phase, those above 60 years and above 45 years but with comorbidities are being vaccinated right now. Now, one interesting aspect here in the vaccination drive concept is that now there is a demand coming in from various corners that there should be a tweak in the present vaccination policy. That is the way, the people who are being selected to go under the vaccination drive as per the age criteria. Even the Supreme Court has recently asked the central government whether it is possible for them to, have that tweak in the vaccination policy. And there are chief ministers of some states which are also requesting for such tweaks. So we'll try and understand whether the time is right now to bring in those changes in the rules, or we have a framework which we should follow and along with that move along with that and achieve all those objectives. And for more on this, we're joined by Dr. Samiran Panda, who is a member of NEGVAC, as well the head of the ECD division in ICMR, New Delhi. And we're also joined by Ms. Urvashi Prasad, public policy specialist, specifically looking after health in NITI Aayog. Welcome, both of you. And let me begin with you, Dr. Panda. Let's start by taking an overview of our vaccination drive program. How far we've gone, what all are the objectives we have achieved so far?
Well, the vaccination rollout that got initiated in the country on 16th of January this year, that had specific objective of reaching out to the elderly population, and also after that to people with comorbidity. There was a science behind it. The purpose of such vaccination rollout plan was rooted in the understanding of the natural history of the disease that clearly said deaths or complications or severe form of the diseases are encountered more amongst the elderly, and also amongst those who might not be called elderly if you look from the age criteria, but are having some form of comorbidities. So the purpose was to reduce the impact of the infection, SARS-CoV-2, and the disease on the probable hospitalization, usage of ventilators, the demand on the healthcare services, and in some situations, the unfortunate events of death. Now, if we go back to the trial data, in any trial, I'm talking about the vaccine trials here, and the vaccine which have been developed and which have been, been given the approval for restricted use in emergency situation, and then it started getting used in the rollout program. There, the end point of the trial was the reduction of the severity. So symptomatic disease or reduction of the severity or the impact on death, these were the primary endpoints. And the secondary endpoint was infection, if possible for us to see, which requires longer follow-up period. So what I would say that the vaccine rollout that took place middle of January 2021 was to reduce the death, reduce the severity of the disease that is expected to happen amongst elderly. Okay. And from that viewpoint, from that perspective, we have achieved quite a lot, but we are still seeing the vaccine hesitancy in some of the individuals, and the states are also performing differently in terms of the vaccine uptake.
Okay. So that's the science behind the entire vaccination drive. Let me bring in Urvashi here as well. Urvashi, on the methodology being adopted to continue with this vaccination drive, that was the science part. If you're looking at the methodology here and in the way the entire vaccination drive is being rolled out, how would you view this helping us in our overall battle against COVID-19 and also the goals we have achieved so far?
Yes, so I think there's a couple of things to keep in mind in terms of the context of this one. Of course, the prioritization that we've used, because lots of people have questions around it, is very much based on global best practices as well. When we look at frameworks that the WHO develops or even the US FDA develops for prioritization, you tend to go with those individuals first who are either at highest risk of contracting the disease, and therefore we went in with the healthcare workers and the frontline workers up front. Or then you go with individuals who are at the highest risk of developing a severe form of the disease, or unfortunately even losing their life to the disease should they get it. And that's where we then went with people who are in older age groups or people with comorbidities. It's also important to note that India has anyway kept a fairly liberal definition of senior citizens. In a lot of European countries, etc., they in fact started by prioritizing people who were much older, 75 plus, 85 plus. Now, India, because we realize we are a younger demographic in general, we've actually gone with 60 plus people for senior citizens and 45 to 59 for people with comorbidities. So we have that factored in already, that we do need to reach out to a much broader net of people. But as you rightly said, that there are certain logistical, operational issues as well that need to be addressed. And this is something the Prime Minister has also brought up in his meeting with the chief ministers. There are certain centers across the country, for instance, which are still not functioning fully, which can be brought to capacity. And there is also a need to address issues like, wastage of the vaccine, which is happening. Some precious vaccine doses are getting wasted in certain centers. So we do need to iron out these operational logistical issues as well. But there is no doubt that we will be scaling up the campaign. In fact, if you see in the last few days, we've consistently hit 2 million doses a day. The highest we've achieved so far is about 3 million doses a day. So I think we are already seeing the pace picking up, as some of that hesitancy is also reducing, because people are now seeing that the numbers are going up and there's actually an urgent need to get vaccinated if you are eligible. So I think if we can iron out some of those logistical operational issues, which is where a lot of the focus is right now, because different states are at different levels, and we can achieve a sort of critical mass in this category that we have currently prioritized, it will go a long way in saving lives. And then, of course, eventually we will open out to a much broader set of people as newer vaccines also become available, hopefully.
Okay. We'll talk about that operational logistics issue there as well, which has been pointed out time and again, and that also needs to be ironed out clearly to ensure that we get the 100% benefit of this entire exercise. The capacity utilization is at its maximum as well. But let's come to those suggestions which I was earlier referring to in the introductory remarks. And Dr. Panda, I'd like to start with you. How would you respond to these suggestions coming in from various quarters, while some state governments are suggesting that those above 18 years of age should be allowed now, and also, the Supreme Court asking the government whether it is possible for them to go ahead and tweak its policy. So the question here is that how does the group which is looking after this entire vaccine administration plan is looking at these suggestions coming in? What's the plan?
All right. So when we think of tweaking or modifying a plan, we need to ask ourselves what are the objectives that we wish to achieve. So if the objective is to reduce the chain of transmission or break the chain of transmission or reduce the speed of spread of the virus, if that could be one. And the second could be reducing the impact or mitigating the negative impact of the disease in the population. So clearly, the vulnerability to the infection is not uniformly present in a society. So it doesn't really make a public health sense if one says that I have a limited supply of vaccines, or whatever supply I have, I want to go out and give it to everybody who is above 18 years of age. So what is the situation we'll end up in if we take that kind of approach? Yes. Anybody who is above 18 can be called an adult. And so if your logic is, this is an adult immunization program, so let's try immunize all the adults. In that situation, we are taking everybody as equal in terms of vulnerability to acquisition of infection, or even we are taking or considering everybody to be at equal risk of having severe disease or even the unfortunate events of getting hospitalized and landing up in severe disease. That is not the case. The natural history of the disease tells us very clearly, and the social dynamics and the behavioral science clearly tells us that the disease transmission happens where the population density is high, number one, and secondly, where people as groups and as smaller or larger groups, doesn't matter, in a social milieu, lower down their prevention guards. So we should direct our vaccination, as Urvashi ji said, that if somebody is by occupational positioning or standing are more prone to infection, they should be vaccinated first. Secondly, those who have the greatest risk of landing up in severe disease or facing fatality. Now, tweaking is fine so long we have the data to substantiate that tweaking. But in the process, if we give one dose to everybody and then we run out of the vaccine in terms of the second dose administration, what would happen? The interval between the two doses would get expanded. So the delayed second dose of the vaccine, here you must be knowing about the debate around Covishield, and people are discussing whether the dose interval should be 4 to 6 weeks or it should be expanded to 12 weeks. I would say that cannot be an appropriate approach, because this analysis, the scientific analysis that talked about greater efficacy if the second dose is administered at 12 weeks, that used very limited number of people, and those kind of data should not be used for taking a public health decision. The most important thing which we should remain aware of is that by increasing the interval between the two doses, we are increasing the chance of that individual who has received his or her first dose of vaccine and waiting for the second dose and acquiring the infection in between. That's called breakthrough infection. So in essence, I am hoping that by delaying my second dose, I will have better efficacy where there is no solid scientific proof, because the uncertainty around that efficacy figure is hugely wide. And I am actually putting myself at risk of acquiring infection between the first dose and the second dose of the vaccine. So I will say that we should not make our own decision of delaying the vaccine. We should all come forward and try get our vaccine at the 4 to 6 weeks interval after receiving the first dose, and there will be a risk of breakthrough infection. The other risk is that if I take the first dose and then I'm waiting for the second dose and actually delaying it, and if I get the virus in between, then my antibody titer is low, and there the virus will get a chance to get mutated. So that is also another risk.
Okay. So if you have to understand this, and Dr. Panda, you've given an elaborate explanation for why we are doing what we're doing right now. But for the next steps ahead, because the way we've devised our vaccination campaign, first it was for the frontline workers and the health workers as well. Then those above 60 years of age and above 45 years with comorbidities were brought under the ambit. Now in the next phase, are we likely to go for lowering down the age barrier or including more professions here? Which is the best way to move forward?
Well, this is being considered. This is under serious consideration by different state health authorities. There could be two ways of going about it. One is irrespective of the comorbidity, if we cover those who are 45 years of age or above, and then also consider their occupational positioning. That would be the smart way of going about it. But I would say that attaining or achieving adequate coverage for the groups that we prioritized, for example, healthcare workers or elderly population or those with comorbidity, that should also not be overlooked, because not attaining the coverage would be disastrous. So I would say that the community engagement, involvement of the community-based organizations, and also to address vaccine hesitancy and behavioral issues along with vaccination would be the smartest thing to do. And not to forget that it's not a very good scientific public health approach to not attaining the critical coverage, but to thinly spread whatever resource we have at hand.
Okay. Okay, Urvashi, your views there on these criterias, various criterias and various suggestions which are coming in to tweak, these ways, methodology and the criteria as well.
Yes, so I think, from a public health perspective, it's clear that coverage is what we really want to achieve when we look at any vaccination program. So it's not just about adding on additional groups or, opening it up further, but within the groups we have, which we know are high risk, that is something that is evidence-based, we need to achieve a certain critical mass of coverage. So I think that has to remain our number one priority. The second thing, as I said, we do need to continuously iron out, wherever there are logistical operational issues, which we can quite quickly address, like the centers which are not yet fully operational. And this is something the Prime Minister has even brought up with specific states that, why are these centers not operational yet, etc. So I think those are things that very quickly on the ground we can address. So that those bottlenecks are addressed. We have seen issues in the past with the COVID app, which we've quickly tried to rectify. So we have been proactive in addressing the issues that have come up, but we need to keep our foot on the accelerator there so that, we don't sort of lose steam. And I think that is something which was a big message that the Prime Minister also gave out, that all states must come up to the same level, especially the states which are seeing an increase in the number of cases. I think there especially vaccination obviously needs to be a very, very important pillar. So I think this is something we need to prioritize for now. Going forward, of course, as I said, as hopefully more vaccines also become available, definitely we might see a widening out of, the number of people who might be eligible. But that has to be done in a very evidence-based manner that can just not be based on what we would like to do or, anecdotal views. That has to be with a very strong evidence base. So I think that is the approach the government will take. But I think finally also on this, I would say that we must realize that vaccination is not the only peg of our strategy. The other one, where we have to continue to adhere to our social distancing norms, our masking, our hand hygiene, that should not be relegated. While, yes, we are all focused on vaccination and we all want to ramp it up, we must not forget that second piece, because somewhere a laxity there is also creeping in. And that is perhaps also reflecting in some of these increased numbers in different states and different districts. So we have to keep a focus and an equal focus on both those pegs of our strategy as we go forward from here.
Okay, definitely. Those two portions of the strategy are equally important there. Let me bring in Dr. Samiran Panda here on an issue which Urvashi has repeatedly raised earlier as well in two responses today also. That is ironing out the operational issues, optimal capacity utilization there. Dr. Panda, I'll just go through the numbers which I have with me in terms of the wastage. Maximum, wastage of the COVID-19 vaccine from the states. For Telangana, it's around 17%. Andhra Pradesh, it's around 11%. Uttar Pradesh, it's around 9%. Karnataka, around 7%. And Jammu and Kashmir, around 6%. These are really, really important numbers. And at a time like this, and when we are facing a pandemic and, vaccine is the best way forward here, obviously, in addition to the COVID-appropriate behavior, this sort of wastage needs to be taken care of and those operational issues which Urvashi were referring to. So what needs to be done?
Vishal, the data that you shared is so very important. Clearly, that data shows that the states are heterogeneous in terms of their performance and in terms of the vaccine uptake. Now, why the vaccines are being wasted? Because there is lesser uptake, clearly. Now, the need of the hour is, if somebody gets a message or a call or is due to go attend a vaccine session site and receives the vaccine, and if the person is not coming forward, so there must be something which is holding him or her back from coming. So that's the crux of it. And we cannot afford to say, well, a few people have not come, so let us open the window for others to walk in and receive the vaccine. Of course, that would have some of the walk-in attendance of the vaccine recipients, but that won't solve the fundamental problem of why those who had their calls or messages going through their mobile or from the COVID software, why did they hesitate? So going back or reaching out to them. So having an outreach component in order to address why was the hesitation would be first thing to address. So we cannot afford to say, oh, okay, it's an individual choice. They did not come forward. Let's open the window. Let others walk in. That's okay. Let others walk in. But those who did not come forward, we cannot afford not to address the hesitancy. That's number one. So how do we address that hesitancy? So we have to have the community-based, our ears and eyes in the community, which would help us to understand this hesitancy better. Third and most important is to address the information which are coming up through social media, TV, print media, because very recently we came across this whole phenomena of blood clots happening after AstraZeneca vaccine. So immediately there was hesitancy. And if we say, oh, let's see how things unfold, that won't do the public health justice. Mm-hmm. So we have to be proactive in order to say that anything that happens after vaccine does not necessarily get caused by the vaccine. So the cause and effect relationship is something which cannot be jumped at or interpreted immediately. So what all I'm trying to say is that if people are not coming forward and taking the vaccine, understanding why is it so. Secondly, in order to understand the hesitancy, how do we engage with the community in order to address them? Thirdly, if there are information which are being wrongly interpreted, for example, the blood clots following AstraZeneca or Oxford vaccine, we have to sort of come up with the proper information. Fourth and last is some of the self-proclaimed experts are also opining, oh, I won't take vaccine, oh, vaccines might have certain adverse events. So anti-vaxxers, they are called, their responses in the media should also be taken seriously, because what is needed today is to increase the confidence of public on the vaccines rather than ignoring if anything is happening that might have the potential to add to the vaccine hesitancy. I would say that.
Okay. Let's take a quick concluding comment from Urvashi here as well on addressing those issues, Urvashi, before we bring this discussion to an end.
Yes, that's right. I mean, I think in general, the trend of hesitancy, we have seen improvements in it from when we started out, when there were many more sort of doubts and concerns around new vaccines. We've also seen Covaxin now being taken away from the clinical trial mode. It was initially given emergency authorization in clinical trial mode, but now that is not the case. So I think the confidence has over a period of time built up. But we are a very heterogeneous country. We have different segments of the population which we are trying to reach out to. So there has to be a decentralized approach. While the central ministry, the government is, of course, putting out the broader messages, trying to address the hesitancy. States and districts need to make sure that we take those right down to the grassroots level with the help of civil society, with the help of local community leaders, so that the concerns that people have on the ground very specifically can be addressed. So I think that is the way forward from here to address the issue of hesitancy.
Okay, definitely there it is. Thank you so much, Urvashi, as well as Dr. Samiran Panda, for sharing your views on this very important aspect of how to make best use of the vaccination drive, and also the suggestions which were coming in about the tweak in the vaccination drive. As our panelists were pointing out, the process or the methodology which is being followed right now is based on scientific evidence, and any changes will also be based on scientific evidence from here onwards. Let's wait and watch as to what exactly the policymakers have to say and decide on this strategy, and we'll get to know that soon enough. But meanwhile, while the vaccination drive is on, let's not also forget about the COVID-appropriate behavior, which is a really important aspect of this battle against COVID-19 pandemic. And it is a three-step simple process. Let us remind you. First is, of course, you have to wear your mask at all times when you step out of your houses. Also, ensure that you wash your hands regularly. Hand hygiene is really, really important. And follow physical distancing norm of at least 6 feet when you are out there in public places. This 3 simple step process will go a long way in keeping you and your near and dear ones safe and secure during these times. So do follow all these guidelines, and we'll come back again tomorrow with a different aspect of this battle against COVID-19. Keep watching Sunset Television. Thank you.